So welcome, everyone. I appreciate everyone joining us today. We're grateful to Dr. Andres Matoso for a conversation around decoding your pathology. To stay up to date with the programming going on at the Greenberg Bladder Cancer Institute, please Google us for our landing page. We have up-to-date information, extended educational resources available there. And follow us on @JHBladderCancer on Twitter. Today's speaker, Dr. Matoso, is an associate professor of pathology and an expert on surgical and urological pathology. He's our go-to #1 for anything bladder cancer. He received his MD from the University of Buenos Aires, followed by residency training in urology in Argentina. He did additional training at Cornell and my alma mater, Brown University, before joining Johns Hopkins in 2017. He is a close partner in our work at the Greenberg Bladder Cancer Institute, and he has a strong interest in the molecular alterations associated with bladder cancer development and progression. Again, I'm very grateful to Dr. Matoso for joining us today, and I'm looking forward to our discussion at the end of his presentation. And I guess, as we did last time for Dr. Platts, if you have questions in the middle, go ahead and ask them. And Andres, if it's okay with you, I may interrupt. Andres, take it away.
Thank you, David. Thank you very much for the opportunity to be here today. I'm going to have a PowerPoint presentation on the general concepts of urothelial carcinoma, and then leave some time for questions that you might have. So let's see if I can. You can see my screen, correct?
Absolutely.
Yes. So I'm just going to go to the point of questions that I get frequently about urothelial carcinoma and terminology used in pathology overall for bladder specimens. One question that often arises is, what is mild dysplasia? And does it mean anything? And in my practice, whatever is close to normal, but not completely normal, I call it normal. And I'm going to show you an image. So I try to avoid the mild dysplasia terminology that nobody really knows. It's a term that some pathologists use because they feel uncomfortable calling normal when there is a slight deviation from a perfect. So the spectrum, like everything in biology, is not black or white, and it's a spectrum of different tones. And the same thing happens with the morphology. And people who are not used to seeing a lot of it will feel uncomfortable as soon as things are not exactly as they would have liked to be. So here we have a urothelium, and this would be an example of something that unexperienced pathologists could call a mild dysplasia or even dysplastic urothelium, and we will call this normal. And the reason being is it has normal thickness, which goes from 1-2 layers to 7. It has a nice umbrella cell layer, and you can see the cells have a slight variation in their sizes and shapes, but they're not hyperchromatic. They're not. Their morphology is overall retained, and they all look quite monomorphic to me. Although for some people, they might think that these are slightly hyperchromatic, and they say, okay, could be a precursor lesion. And that's the idea, that we call dysplasia things that might turn into a low-grade carcinoma in the future. We have lymphocytes usually within the urothelium. These are lymphocytes. Those are inflammatory cells. They have a very small nucleus, and normal nuclear, the nuclei of normal urothelium are usually 2 times or 2.5 times the size of a lymphoid cell. So we can use this for comparison, and you can see that these are 2, maybe 3 times the most. That would be normal. Now, the other side, another flat urothelium that would be clearly malignant is a carcinoma in situ. Carcinoma in situ doesn't have a grade, it's high grade by definition. And some people have used the severe dysplasia term, but again, we don't use that. And what we leave only dysplasias are for cases that don't meet criteria for carcinoma in situ, but that are clearly abnormal and not like the case I showed you before. So there are different types of carcinoma in situ. This is clearly different than the other urothelium that I showed you before, where you can see the cells have marked nuclear irregularity, hyperchromasia, multiple mitosis. And the nuclei, you can see the different sizes and shape. Some of them lost their orientation. They don't know where their base is or where the luminal aspect of the bladder is anymore. So this is high-grade carcinoma. It's superficial, non-invasive, and this is carcinoma in situ. Sometimes carcinoma in situ can have this appearance where the cells are discohesive and they're falling off, and you only have 1 or 2 layers of cells attached to the surface. But these nuclei are very large. You can see here the lymphoid cells. They're 3, 4, or 5 times the size of lymphoid cells. And they're discohesive, which is one of the features of carcinoma in situ. Then underneath in the lamina propria, there is no invasion. And sometimes in patients with carcinoma in situ, we have a mucosa like this, where you have completely denuded surface. So in this case, we cannot call it carcinoma in situ, but we call that the mucosa is denuded, which means that it could be a case of carcinoma in situ where all the cells have shed. And those patients require follow-up for a definitive diagnosis. Sometimes carcinoma in situ would present like in this image, where you have a normal urothelium with isolated tumor cells. This is called pagetoid carcinoma in situ. So there are different forms of carcinoma in situ. They all have the same meaning. They're high grade, and they have a significant risk of progression to invasion. The main problem with carcinoma in situ is that the urologists often do not see it by cystoscopy or even with blue light cystoscopy, which increases sensitivity of detection of carcinoma in situ. Dysplasia would be a change that is a little less than carcinoma in situ. Here you can see a urothelium with some of the cells larger, hyperchromatic, but it does not look as ugly as the ones that I showed you before. So this will be a dysplastic urothelium. And in order for people to understand, I always tell them that the urothelium in a flat lesion that is dysplastic looks like a low-grade papillary urothelial carcinoma. And it might be a precursor to a low-grade papillary tumor. So they need to be followed. And that's what does dysplasia mean for our urologist? If the patient had CIS, it means it's coming back. If the patient doesn't have CIS, and this was detected as the first sign, then they get followed because they have more chances of developing a carcinoma, a papillary urothelial carcinoma in the months or years to follow. Now, one of the differential diagnoses are reactive urothelium, and reactive to what? To inflammation. So when we have a urothelium that looks like it could be neoplastic, but there are a lot of neutrophils, as we see here, a lot of inflammatory cells. For example, a patient with cystitis, the cells might look a little larger, and this could be something misinterpreted as a carcinoma in situ, but in the presence of inflammation, we have to let these changes go and maybe treat, and then afterwards repeat the biopsy. Carcinoma in situ can be very difficult to diagnose, so sometimes we use immunohistochemistry stains, and some of the most commonly used are CK20 and P53. But we rely exclusively in morphology, and we do not use these as often. But people who are not experts on bladder pathology, they resort to these markers a lot more, and they have their own set of confounding issues, so they're not that easy to interpret. This is a CK20 in a normal bladder urothelium, where the umbrella cells are positive. In contrast, carcinoma in situ will have diffuse positive staining for CK20. But this can be seen in rare cases of inflammatory changes or in dysplasia. So by itself, it is not a diagnostic of carcinoma in situ. There is also a subset of carcinoma in situ that can be negative for CK20. So also negative staining does not exclude carcinoma in situ. The result of these shortcomings of the staining is that we use morphology to make the diagnosis. P53 is normally present, the expression in the nucleus is normally present in rare cells, in benign urothelium, and is diffusely positive in carcinoma in situ. This means that P53 usually, this pattern of staining means that this tumor suppressor gene is mutant and the protein is non-functioning. And because it is non-functioning, the cells produce more proteins, and then you see it overexpressed by immunohistochemistry, but this is a non-functioning P53.
Hey, Andres,
yes.
what fraction of carcinomas in situ have this mutant P53 pattern?
Yeah, it is the least sensitive of them. It is present possibly about 30 to 40% of the classic carcinoma in situ.
Thank you.
Yeah. When present, this can be very helpful, but this is another stain that has its own pitfalls. For example, this is a very inflamed benign urothelium, and P53 will look like this. And for some people, this would be a little difficult to interpret, and they might call it positive if they're not used to the P53 assessment. Okay. Another term that you might get in your report is papillary urothelial hyperplasia. This is seen by the urologist as a velvety mucosa. It seems like it has a carpet or a rug in a certain area, and then they biopsy this area. And then the urothelium, what we see is a little tented urothelium, but it has a completely benign appearance. This can be seen as a precursor of papillary tumors, either papillomas or low-grade papillary urothelial carcinoma, or in shoulders of a low-grade tumor, either a papilloma or low-grade papillary urothelial carcinoma. So they get followed. It has to be differentiated from what would be CIS or carcinoma in situ with little papillary projections. So this is a carcinoma in situ that is trying to turn into high-grade papillary urothelial carcinoma. You can see the cells are discohesive, as I have previously described. They're also darker and larger. So this is completely abnormal. This would also look velvety, but it usually looks a little bit more congested to the eyes of the urologist.
Hey, Andres?
Yes.
You've got a question in the chat.
Yes.
From Betsy.
Let me see if I can get the chat here.
Otherwise, I can read it to you.
Can you read it for me? Yes, please.
My urethral adenocarcinoma has been attributed to malarianosis. Hoping to hear a bit about that. Okay,
very good. Okay, so we make a little break here. The urethra in women sometimes develop a type of adenocarcinoma, often with the morphology called clear cell adenocarcinoma. And it is thought to derive from little foci of either endometriosis or endosalpingiosis, basically some rests of endometrium present in the urethra that follows a pathway into an adenocarcinoma. And that's a specific type of adenocarcinoma. And it's more common in women in the urethra, but they can also happen in men. And it has a strong association with endometriosis. And I can comment more about that after the presentation.
Thank you.
So papillary hyperplasia, it should also be watched as similar to a dysplasia diagnosis, because those patients have a tendency to develop a neoplasia later on. Papilloma would be the benign player of all the papillary tumors. So for some reason, the bladder likes to make tumors that are papillary. Papillary means that they have finger-like projections, and it grows in an exophytic way. It can also grow endophytically, but most commonly as exophytic, and it looks like a little cauliflower or a little broccoli inside the bladder. That's a papillary lesion. Some of those lesions could be benign, and those are papillomas. So you see here the core, or the fibrovascular core, lined by completely normal urothelium. Mitoses are rare, papillomas are benign, and rarely will recur. Some papillomas will recur that are more likely represent low-grade papillary urothelial carcinomas that were misdiagnosed as papillomas. But the most commonly is a benign diagnosis and does not mean anything. They're more common in younger patients, but it can be diagnosed at any age. And they're usually small. They are diagnosed because they bleed. Yes.
Another question.
Yes.
Is endometriosis possible in a woman who has had a total hysterectomy?
Yes.
Hoffman's question.
Yes. Endometriosis is something that starts, it's an embryologic condition. So it's something that develops during embryogenesis. So it takes sometimes years and years to develop any symptoms. Depending on the location of the endometriosis, it might be symptomatic or it might be completely asymptomatic. Once you remove the uterus and the ovaries, the foci of endometriosis do not cycle anymore like normal uterus do, but they stay dormant. So if a woman has had a hysterectomy and oophorectomy, both ovaries and uterus is gone, any endometriosis that was adjacent to the uterus will be gone. But if there is endometriosis somewhere else, that will stay. Endometriosis can happen anywhere. It could be in the lungs, could be in the GI tract, and cause a little hemorrhage in every cycle. And the hemorrhage will disappear after there are no more ovaries and there is no more menstrual cycle. But the focus of glands will stay. So cancer can develop from those foci even years after there is no more ovaries or uterus.
Thank you.
So papillary urothelial neoplasia of low malignant potential is basically like a papilloma, but it's thickened. And this is a diagnosis of exclusion. It doesn't have the atypia of a carcinoma, low grade, and it's not completely benign and normal like a papilloma. So we reserve it for those cases where it's a papilloma, but it's too thickened. There is some degree of hyperplasia and proliferation here, so it's not completely resting. And those we don't know how they behave, and some of them can recur, but some of them might not be an issue for that patient anymore. You can see here some of the cells are a little bit more hyperchromatic, larger, but there's no mitosis, and they still retain the polarity and quite monomorphic in terms of the nuclear features. Now, papillary carcinoma can be low grade or high grade. This is an example of a low-grade papillary urothelial carcinoma. You see some irregularity in the nuclei, but it's not terrible as I showed you in the CIS. Now, the high-grade papillary urothelial carcinoma looks like this, a lot more hyperchromatic, a lot more impressive in terms of the nuclei have a lot of variation in sizes and shapes, and they lose their polarity and their frequent mitosis. And this is a high-grade. Both low-grade and high-grade have risk of recurrence that is very significant. This is why bladder cancer is one of the most expensive or the most expensive disease, because of the surveillance that they require, because they have a tendency to come back. The difference between high-grade and low-grade is that high-grade tumors also have a significant risk of progression or becoming invasive, while the low-grade tumors have much lower risk. They can still become invasive because and that's why we call them cancer, but it's much less than carcinoma high grade. So here we see the pollen lump or the papillary urothelial neoplasia of low malignant potential. These are the risk of recurrence. So they can recur, but some of them might not. And you can see low grade and high grade, they're very similar in risk of recurrence. But the high grade has a slightly higher risk of recurrence, but this difference is really not that significant. So if you had non-invasive high grade and low grade, what's the difference between those two diagnoses? If you have a high grade non-invasive, you have risk of recurrence and risk of progression into invasive disease. If you have low grade non-invasive, you have the same risk of recurrence, but less risk of progression into invasive disease. Now, this is the risk of progression. You can see here the sharp contrast between high grade and low grade. And low grade is similar to pon lump of low malignant potential, and they have much lower risk of progressing into invasive carcinoma than the high grade. And this is the risk of death also. So low grade and pon lump has zero risk of death of urothelial carcinoma, while low grade has very minimal risk in 15 to 20 years, and high grade has significant risk of death by urothelial carcinoma at about 20% in 15 years. Okay, now we're going to talk about muscle invasion. So there is a lot of questions about this. The bladder has two main layers of muscle. So this is a normal bladder mucosa. Then you have the lamina propria that is commonly has some inflammatory cells. You see them here. Then there is a layer of a smooth muscle, which is involuntary muscle, that is called muscularis mucosae. And it's this layer right here. This is not what the urologists refer to muscle invasive disease. This is part of the lamina propria. And this is commonly a problem in terms of staging a invasive cancer, whether it's involving this muscle or the true deep muscle that the urologists call muscle invasive cancer. Right under the muscular mucosa, which can be very thin and sometimes not even obvious to identify, there is a plexus of very large vessels that sometimes help the pathologists to orient themselves to see where is deep and where is surface. So here we have a surface with normal urothelium, lamina propria, large vessels, and deeper here would be the muscle. This is the deep muscle or muscularis propria. So we have the mucosa, muscularis mucosae, the blood vessels here, and the deep muscle. When the tumor gets into the deep muscle, that's what the urologists call muscle invasive disease. So here, it doesn't fit in one picture, excuse me, but you can, we will have the surface up here and the deep muscle here. You can see these thick muscle bundles, and this is the line that separates what would be non-muscle invasive cancer if it's involved in this area and muscle invasive cancer. And what's the difference clinically is huge. What's called non-muscle invasive cancer has a survival of 88% in 5 years. While if you have muscle invasive cancer, the survival projection is 60% in 5 years. And this is why once you get deep into the muscle, the therapy would include a cystectomy. While non-muscle invasive bladder cancer can be managed mostly with intravesical BCG or conservative therapy without having to perform a cystectomy, unless the tumor proves to be resistant to the conservative management, and then cystectomy becomes an option to avoid death of disease. So lamina propria invasion, is seen here. For example, we see a little nest of tumor that will involve the stroma right underneath the surface. And this would be a T1 cancer for staging purposes. It's invasive carcinoma, but does not involve the muscle. So this is an example of non-muscle invasive bladder cancer with invasion into the lamina propria. Sometimes in the papillary structure, the invasive component is limited to the stalk, to the fibrovascular course. So this here is non-invasive carcinoma, and in the center, we have an area of invasive high-grade urothelial carcinoma. This is also an example of non-muscle invasive bladder cancer. Now, this is an example of muscle-invasive bladder cancer. You see the nest of tumor is surrounded and involving the muscularis propria. This is an example. When we see this, we call it muscularis propria involved. And these are patients that, in addition to chemotherapy, or they have to consider cystectomy. This is another example of tumor cells in between thick muscle bundles involved by cancer. Sometimes the distinction of involvement of muscularis propria can be very challenging microscopically, like in this case, where the tumor is digesting the muscle, and it requires a lot of attention to try to identify some residual muscle in between tumor cells so that we don't understage those cases. This is another example. This is difficult to distinguish whether all this pink fibers here is collagen and reaction to the tumor versus digested muscularis propria. Here we see little tumor cells going in between all these collagen fibers. And sometimes we resort to immunohistochemistry stains again, where desmin is a protein that is specifically expressed in muscle and highlights the muscular nature of all these little fibers that we were seeing. And we see tumor cells in between that are negative for desmin, and desmin is highlighting all the muscle, and that's another helpful thing. So once we have determined the stage, other things that we do are PD-L1 expression, and PD-L1 is tested for eligibility for immunotherapy. So this will be a break to the immune system, and it can be targeted by a drug. So if PD-L1 is expressed, those patients have higher chances of responding to PD-L1 inhibitors. And the reason why you give inhibitors is that your own immune cells can recognize tumor cells and kill them as strangers. If they have expression of PD-L1 on their surface, that would provide a break to your immune cells and tell them, no, don't kill me. So we want to target that, and that's why we do the immunohistochemistry, and we report that as part of our reports. There are certain histologic variants or many histologic variants of urothelial carcinoma, and the clinical significance is that some of these are more aggressive. And now as we move more and more into personalized approach in bladder cancer, this a variant can have also a significance to response to potential therapy, as we are learning more about this. So some of the variants are nested, micropapillary, sarcomatoid, small cell carcinoma. All these on the top are known for being more aggressive. So some patients, even though if they don't have invasion into the muscle, but they have these variants, and their goal is long-term survival, they would get offered a cystectomy even prior to the tumor becoming muscle invasive. So that's why it's important to recognize these variants. Small cell carcinoma, in addition, would be also a targetable by different chemotherapy. So it's important to get recognized. These are examples of lymphoepithelioma-like carcinoma. That is a variant. This is a plasmacytoid urothelial carcinoma. It is very similar to gastric sigmoid ring cell carcinoma or lobular cancer of the breast. Another variant is osteoclast-rich undifferentiated carcinoma that can look like anything but urothelial cancer. So you have to be aware and be able to recognize it as a variant of urothelial carcinoma. These are examples of small cell carcinoma. That is a neuroendocrine carcinoma. It can be pure, or it can be mixed, as we see here, with conventional urothelial carcinoma.
Andres, question?
Yes.
How do you find these variants? By genetic testing or by eye with pathology?
By eye. This is why I'm showing the images, because what we look for, these are morphologic variants. So these are variants that are recognized by the pathologist as a morphology by having features that are different than the conventional urothelial carcinoma. So, for example, plasmacytoid is characterized by single cells invasion like this with some space surrounding them. They lose E-cadherin, so they're very loosely cohesive. So every time we see this morphology, we consider it plasmacytoid. There are some of them would require to perform some immunohistochemistry to be able to recognize them. For example, this is a lymphoepithelioma-like carcinoma, and the reason why it's called like this is because at low power it might look like a lymphoma, but if we perform cytokeratin, there is a stain that will highlight epithelial cells. You can see nest of cancer cells in between lymphoid tissue. This variant has a particular interest because there are some case reports that patients with this variant have a higher response to chemotherapy, possibly related to a more brisk immune response. So some clinicians will consider chemotherapy and wait and see if there is response before performing a cystectomy. And Dr. Epstein always tells a story about a patient who sends him a gift every year after he changed the diagnosis to a lymphoepithelioma-like carcinoma and was able to preserve his bladder and has been free of disease for many years now. This is a plasmacytoid, osteoclast rich. It looks like a sarcoma. So this out of context may be misdiagnosed as a sarcoma, and it has giant cells that look similar to the ones seen in osteosarcoma. So it's important that the urologist, the pathologist is able to recognize this as a variant of urothelial carcinoma so it doesn't get named something else. This is a small cell carcinoma that here we see, this is a pure small cell carcinoma, and here you can see that this is a mixed because you have some nest of cells that have more abundant cytoplasm. This is the normal morphology of a conventional urothelial carcinoma, and then is surrounded by little clusters of tumor cells. They have very scant cytoplasm, and this is the small cell carcinoma. This is important to be detected because those patients, when they undergo chemotherapy prior to the surgery, they have to add neuroendocrine specific chemotherapy, for example, etoposide. And they can do very well if the right chemotherapy is given in advance. So we perform a lot of second opinion consults from anywhere in the country and around the world. And what are the reasons why people send their pathology for a second opinion or review or consult? About 20% of the cases get changed. So which is quite significant. What are the reasons for changes that can impact the care of that patient? For example, one of the most significant is to diagnose a metastasis versus primary. Something has been called urothelial carcinoma, but is instead spread from cervical cancer in a woman. And that is significantly different because it has to be treated differently, and you don't want to do a cystectomy on a patient who had already disseminated disease from a different organ. And that is a very aggressive surgery that can be avoided if diagnosed appropriately. For example, other cases are benign versus malignant nephrogenic adenomas or paragangliomas, which is a benign tumor, can mimic an invasive urothelial carcinoma and be misdiagnosed as a malignancy, and patient could undergo a cystectomy where the patient didn't need it. Morphologic variants, as I explained, some of them have different prognosis and different treatment options. So they also have to be diagnosed. And then finally, evaluation of muscle invasion can be quite difficult and very important for management. And I think with this, I'm gonna finish now. And I just wanted to show you that there's a couple of resources for patients who are considering their biopsy to be read by a second pathologist. Most of these second reads are covered by the patient's insurance, and those that are not covered, depending on who triggers the second opinion, either the hospital or the patient might get a bill, which varies from $300 to $350 or something in that range. And that information can be found here in the website. And then we also have a bladder cancer website for pathologists that I have designed, and it has a lot of the information that I gave you in this presentation that you can navigate through it. Maybe I can show some of it. Let me see.
You may have to stop sharing and reshare.
Yes, I'm gonna stop sharing and reshare. Yeah. So this is the bladder cancer website that I have developed, and you will find different bladder cancer basics, like overview of bladder, about bladder cancer, explain my results, my options, second opinions, treatment options, and you can go and it has all the information that I provided in this presentation and more in a website format. There's also an area for different terms that you can search for the meaning of terms that you might see in your report. And also a guide if you would like to send your case for a second opinion. You will find that here too. Let me see. I think in my options, the pathologist role, and somewhere, yeah, get a second opinion. In my options, second opinions, and then here you can check, and it will direct you to the other website I provided, where it has everything explained on how to submit your second opinions and what to expect. The turnaround is usually, once we get the slides, it's within 24 hours you will get a report, unless there is a need to perform additional studies. And with this, I stop now, and I'd be happy to answer questions or any comments.
Thank you, Andres. I learned a lot today. So how hard is it to diagnose these variants, or to identify CIS? Because to those of us who don't do this every day, there would seem to be some very subtle differences among some of the things you were showing us.
Yeah, bladder pathology it requires a lot of experience. So it is quite a challenge for a lot of regular pathologists. So it's just a matter of experience and being able to do it with enough volume to be able to recognize when you're seeing it. So that's the main thing. It's like that story about the man in Istanbul. So there was this John who went to Istanbul for work, but he always lived in New York, and then he would get out of his apartment and say hi Fred every morning, and see Fred going to work, and then he gets to Istanbul and he sees Fred going to work again. He's in a hotel. He's all confused, so he doesn't wave and doesn't say hi to Fred because it's out of context. And that's an example of what happens to pathologists that are not used to seeing bladder all the time. They get confused and they don't see the things that you see when you're seeing it all the time. And this master in pathology used to say that there are only two people to whom this doesn't happen, is that those who wouldn't recognize Fred even in New York, and that happens to, and those who never get out of New York. So so it can be quite tricky. Some of the variants are not recognized for lack of experience, and some of the variants, the people don't even know about them.
Can you tell us? Oh, I'm sorry. So we've got a question from one of the audience members. How do you find these? Oh, I see. Okay. What are the pathological differences in diagnosing cancer in the bladder versus the upper tract? Do the stains look different?
So the upper tract and the bladder are very similar, and the difference you have in the upper tract most commonly is that that it invades directly more rapidly, but it's very similar pathology. They have stains that are slightly different. Like, for example, bladder is positive for GATA3, while upper urinary tract tumors are negative for certain markers and positive for others. So they might trigger confusion, for example, with renal cell carcinoma. So one in the upper tract, one of the main problems that we see are cases misdiagnosed as renal cell carcinoma as opposed to urothelial. So that's the main trick. And then it gets treated differently. You don't lose the bladder, which is, luckily we have two kidneys, so you can get a treatment with a nephrectomy and hopefully have a good survival and without having to lose the bladder or kidney function. So in a way, it can be a better situation than having bladder cancer.
Another question, is there any other way to confirm high-grade or low-grade tumor except morphology?
Yes, some of the borderline cases we resource to Ki67, which is a marker of proliferation. So low-grade tumors usually range around 5%, while high grades are higher than 10%. So we do this marker, and nuclei that are about to proliferate will be positive. So then you count overall the number of tumor cells, and if it's very low, less than 3%, for example, is definitely a low-grade tumor. And sometimes that's very helpful in small biopsies, or sometimes what we have used recently in cases where the nuclei look atypical or very large, but we are uncertain whether this nuclear changes is degenerative due to the sample having been placed a long time on the counter, for example, before being analyzed by the pathologist, and the cells become, they look like high grade, but they're actually undergoing degeneration. So then it's good to see which ones, whether it's true atypia or is it atypia secondary to the processing of the samples. In those cases, we use Ki67. But at the end of the day, in 98% of the cases, the assessment is morphological. So that's also another important factor to send it to a place, your pathology to a place where they're used to grading the tumors. Especially in small tumors that are less than 3 centimeters, the grade changes your eligibility for BCG intravesical therapy. If your tumor is less than 3 centimeters and it's low grade and it's a single event and it's your first event, those patients might not need to do any intravesical therapy, just a follow-up.
So a question from Vicky. If you're being treated at a community level, should you always get a second opinion on your pathology from an academic hospital by someone who looks at bladder pathology all the time?
Well, I say yes, but I don't want to be self-promoting. I can tell you that 20% of the cases get changed. So that's the data that I give. And it's up to the patient to decide, do I want to take that risk of having 20% chances of having a difference of opinion, or I'm comfortable with my situation the way it is now?
Yeah, I'm aware of a case myself where the patient was diagnosed with a high-grade cancer and was recommended for radical surgery, and a sample was sent to you folks and turned out to be benign. So, again, dramatic difference in what happens to you afterward. What about the quality of the biopsy? Again, if you can comment a little bit about staging and the quality of the biopsy, that would be helpful.
Yes, the quality of the tissue is very important. And many urologists recognize this. In our institution, we don't have a problem. In other places, the urologists are not getting enough feedback from the pathologist and maybe using too much electricity in order to avoid bleeding. When they do the TUR, the transurethral resection, the end of the resectoscope has electricity, and that burns the tissue and avoids bleeding. So for the urologist, it's very convenient to have high heat and burn the base, have no bleeding, but that distorts a lot the tissue and sometimes will obscure important findings like vascular invasion or even a specific morphology like a micropapillary variant. So I have had a situation of a young patient that had been going around and multiple consults because of the question of micropapillary. And it was so difficult because other people have called it micropapillary. And when it got to me, I said, you know, I see a lot of heat here. And I think this micropapillary could easily be a side effect of or an artifact of the heat. So if I was you, 27 years old, I wouldn't get a cystectomy right now. What I would get is a close follow-up and maybe a repeat a biopsy with knowing that the least heat possible that will help to be able to accurately diagnose a variant. And that knowing that the urologist can do even no electricity whatsoever in the first sampling, just pushing it and trying to get anything that they can without use electricity and submit that first in a separate container and then submit one with the regular TUR. So that way, at least we have some tissue that has no artifact. So the quality is very important.
So I've got a couple more questions
Yeah.
here. So this may be a dumb question, but for someone who has been treated for non-muscle invasive bladder cancer with BCG, would you still see tumors in the post-treatment pathology? Do they disappear or change shape?
Yes, treatment effect can be tricky too. And I always teach to my fellows that there is a momentum that they get and say this patient had a history of CIS. Let me call this CIS because this patient had a history of CIS. And I keep on telling them, you gotta be careful, more careful the second, you always be careful, but even more careful the second time around. Because if you're calling CIS now, this means that the patient is gonna be a candidate to cystectomy and has not responded to therapy. So this follow-up biopsy is super important. And there are a lot of changes that are related to therapy that to people who are unexperienced, it might look like it is diagnosable of CIS. And we hold back a lot because we know that first, it can be secondary to the therapy if the therapy has been relatively recent. And second, we know that this means to the urologist that the patient is non-responsive to the conservative management and that they might need to do a cystectomy. So yes, treatment affects the morphology of the cells. It can mimic cancer when it's not and it's reacting to the therapy. Treatment, it triggers a lot of inflammation. And as I showed you, that's a pitfall. When the urothelium is inflamed, it looks very ugly and it can mimic cancer. So yes, everything is different after therapy. The tumor doesn't necessarily mean there are guidelines for the urologist and they have to do a number of cycles and wait 6 months. And then when it recurs, like recently I had a case where the patient had been diagnosed with recurrent CIS, and before going to cystectomy, our urologist said, let's have it reviewed, and I wasn't able of diagnosing CIS. I wanted to see a new biopsy. I thought they could be easily related to therapy. So that is a very good point, and I think if any pathology has to be reviewed, is the one that is going to trigger your cystectomy. And if anything is going to take a major consequence, that's the one you want to get reviewed.
So here's another question for you. What is the future of pathology multiplexing immunofluorescence, machine learning classification, et cetera.
Yeah, I think all those tools, like everything in medicine, is adding to. And nothing is 100% a solution for any of the problems we have. And this is why medicine keeps getting more expensive and more expensive. And then every time we have something new, it adds to the tools that we have available, but it's not 100%. So I believe pathology is just evolving now because we know more and more about the targeted therapies, and there are different things that we have to look for and adapt our reports based on the therapies available so that we provide that information. So it's going to change. Machine learning is helping a lot, and hopefully will help to decrease volume seen by pathologists and let us spend more time in intellectually challenging activities and not very routine cases. So machine learning can be very helpful, especially it's going to be helpful to address the shortage of physicians in the years to come, which is predicted to be quite serious in 10 to 15 years as population lives longer and the number of physicians, the new physicians are not covering for all the people retiring. So machine learning is going to be critical there to at least screen the negative cases, like we do in cytology. In terms of multiplex stainings, we already are using many of them. And for example, we use PD-L1 in combination with CD8, which is a marker of T cells, and that will help detect the areas that express PD-L1, whether they're at the same region of inflammation, meaning that if you treat that tumor, it will have a significant response or in a way to predict therapy. Most of this is in investigation stages right now in research, but for sure it's going to translate into biomarkers of routine care. And I don't know if there was any other things molecularly.
Or just whatever you think is going to be the future of pathology.
What do I think is going to?
Yes, what do you think is going to happen in the next 5 years to the way you practice pathology?
Yes, so I think it's going to be more and more personalized reports based on the options available for a specific tumor, age group, type of immune response, muscle invasion, non-muscle invasion. So instead of having the same type of information for every patient, there's going to be given some of the basics findings, additional information that will be included in this in that particular patient's report, and not in all of them. So I think it's just going to be more variations and subtleties in that are going to be person specific in order to address opportunities of care.
So here's another question. Can you explain how you sequence tumors from the pathology slides? Can you walk us through the process? And is sequencing now widely available?
Sequencing is widely available to anyone. If it is not available in your pathology department because you went to a small community hospital, that's okay. You can still send it either to commercial labs, for example, Foundation Medicine. But there are others. Suppose Foundation Medicine, the way they work, you call them and they will take care of it. They will fax a request to the pathology department. I will get that request. Someone will give me that request, and I have to pull the slides and select a good area to be sequenced. And then that material gets sent to the lab where they would do the extraction of the tissue, process that tissue, isolate the DNA, the RNA, whatever it wants to be sequenced. And then that DNA gets run through a machine. The machine was sent back to a molecular pathologist, a raw data. That raw data will have a whole bunch of mutation points, and that expert in molecular pathology will determine which ones of those alterations are relevant and can lead to some pathogenic genetic alterations, and which ones are not real or will not have any significance. And then there was going to be a list of alterations that could have potential impact. And the company or our lab in the hospital will match that information with available drugs or clinical trials. So you get a table and say you have FGFR3 mutation, and this is a target of X drug, and these are the sites where you can find information about clinical trials.
Thank you. So I'm not seeing any other questions in the chat. Does anybody else have any questions before we sign off? Well, again, Andres, I just wanted to thank you. It was a brilliant and very thorough review. And I learned a lot. And I think a lot of other people did based on the questions. And I hope that we have an opportunity to do a lot more of these in the future.
Sure, and again, like if there is a question regarding any of our reports or anything else, you can go through that website and find the answer, or just email me, and I'd be happy to set up a phone call with anyone. I have a lot of patients who call me directly if they need any explanation about their pathology. We are not hidden behind in the backstage all the time. So oftentimes we do, and the urologist will say, okay, these questions are way beyond my ability to answer. Why don't you just call Andres directly? So then I'd be happy to talk to any patients or relative of patients or whoever has any questions about pathology reports. And thank you, David, and everyone else for organizing this. It's my pleasure to be here, and happy to be of any help to anyone.
Everyone stay safe, and we'll see you again soon.
Thank you.
Thanks.